Good evening, and thank you for joining us tonight for Ask Me, our educational webinar series sponsored by Mitsubishi Tanabe Pharma America. My name is Audra Hines, and I'm the Vice President of Care Services for the ALS Association Golden West Chapter. We're pleased that Andy Fujimoto, President of Mitsubishi Tanabe Pharma America, is also in our audience this evening. Thank you so much for your generous support. All of us at the ALS Association Golden West Chapter recognize that COVID-19 has a unique impact on the ALS community. During this adaptation to unexpected life changes, our focus continues to be on serving the ALS community by providing timely and impactful resources, including ways to stay centered and opportunities to connect with each other now and always. These include online support groups, in-home connections with care managers via Zoom, and frequent communications with our clinic directors in order to stay best informed on the most current information about COVID-19 and ALS. If you would like to learn more about our programs and to support the chapter, please visit our website at www.alsagoldenwest.org. Tonight, we're proud to host this special program on COVID-19 and the ALS community. Our guest speaker this evening is Dr. Robert Baloh of the Cedars-Sinai ALS Center, which is an ALS Association certified treatment center of excellence. Please join me in welcoming Dr. Baloh. Dr. Baloh, how are you this evening? I think you're on mute. I can't hear you. If you go down to the bottom, maybe.
Sorry, it had disappeared. I was mysterious. I promise. It wasn't my fault.
That's okay. No worries. No worries. Thank you so much. We're all getting used to the technology. No problem.
Well, let's face it. If I had to do another Zoom meeting, I'd probably go crazy just like everybody else. We're all looking for some human contact, but this is great. No, I'm really happy to be here.
Thank you so much. We're happy you're here. As you know, we have some questions that were posed before this call, so I'll start with those and we'll move on to some other questions in the live chat. For anyone in the audience, please feel free to ask a question at any time through the Q&A function at the bottom of your screen. So we will start out with the first question that says, I have a patient who's unable to get her port inserted because of COVID-19, and she's currently in a holding pattern. She's more afraid of progression of her disease than risk of exposure to the virus, but feels a lack of control in her care to gain access to the treatment. Is it possible to access the port without having the home care nurse come in?
Well, it's a good question, and thank you. There are several parts to it. I mean, I think the first part is this whole question we all have is sort of what's the risk benefit of leaving the house? We all know that ALS is a progressive disease and needs treatment. It was brought up earlier, almost every day we have to reconsider the answer to these questions. I would say for right now, the beginning of the question was they can't get a port inserted, and I'm confused as to whether the patient has a port or doesn't have a port. If they don't have a port, they would have to go in and have the procedure done as an elective procedure. And right now, most places are not doing elective procedures. I can tell you that our hospital and most others that I know about are actively looking at reopening, doing elective procedures on a basis where the volumes were appropriate for the risk and the density and everything else. So that soon may change. As far as accessing someone who has an existing port, without someone coming in the home, really without the proper training, I don't think it's a good thing to do. And so while the answer right now, I think, is no, I hope that we can answer soon and say that we can have people coming into the home safely. I think that already is the case in a way. If you have home healthcare workers who need to come to the home and are properly screened, the risk there is not significantly higher than going outside of the house to a grocery store or something like that nature. And in fact, it's probably less. But the question implies everything is a risk benefit. And on a daily basis and an individual basis, we're trying to decide what's the right answer with the background of of ALS being a severe disease, a progressive disease, one that we're trying to do as much as we can for on a daily basis. So I think I answered the question. I hope that, for example, getting that procedure done, that's likely to change relatively soon. And whoever is asking that can get back on track, hopefully soon.
Wonderful, thank you. Next question is, we need immediate support to transfer or start home infusion therapy. Can I still go to an infusion center?
Interesting, yeah, right. It's almost the same question in reverse, right? In terms of having someone come to the home as opposed to going to an infusion center. And honestly, I don't know that we can say right now whether one has more risk than the other. You know, for example, essentially every hospital, our hospital right now, is screening all employees who enter the facility. All employees are wearing masks. They're screened for whether or not they have a fever, symptoms, just to enter the building. And we're all starting to unravel or roll out, I should say, you know, more screening testing, antibody testing, these other things. They're in the very early stages, but we're starting to see that more. You're going to see that most in the setting of the healthcare location, like an infusion center. So one could argue that you're going to a very safe place. No doubt the safest possible thing is not to leave the house at all. We all understand that, but we're all, whether one has ALS or not, grappling with how do we reopen, how do we redo the things that we used to do on a normal basis, and what level of risk do we accept. So I guess what I would say is that while we're just coming out of this period right now, right, of, hey, we all hold up and we said, let's just put everything on pause. And now we're starting to reevaluate, knowing that it looks like that the peak number of cases that we're going to get, at least in California, is not going to overwhelm the health system. That was goal number one. And we went on quarantine early. It clearly seemed to have worked so far. We have not seen the type of situation we have in New York, New Jersey, and some other places on the East Coast, where just a matter of days, probably, with a difference in them getting overwhelmed. So now we can start to reconsider what to do next. And one of those will be having patients both come to facilities to get procedures, to have infusions. And I think I would say that I feel that it's safe to do at this point. That, you know, while it is not absolutely risk-free, nothing is absolutely risk-free, and it's relatively low risk. Certainly much less so than going to a grocery store, going to another place where really there's not the type of screening one has for the individuals entering that place as there is in a healthcare facility.
Terrific, thank you. The next question is, will my insurance reimburse for my diagnosis or for my medication prescribed via telemedicine?
Yes, and in fact, this has been an area where we've seen some, I think, real progress in that Medicare and payers have really rapidly changed their policies on paying for telemedicine, both the visits as well as the care that's provided over telemedicine. So the answer, quite simply, for medicines is yes, and it's essentially always yes. You know, and I think that we're all, again, and Kathy Lomenhurth is going to come on in sounds like a week or two, looking at how we can incorporate telemedicine in a more routine basis anyway. And that, in fact, if anything comes of all of this that would be good, one of them will be that. How can we deliver care better to patients to not have them, if it's not just COVID-19, but just convenience for them to get that care? And that situation we already face. And we're starting to see payers change. And I think one thing we can hope is that that will persist, because the patients will demand it and say, hey, this is working better for me. And the providers will as well. So that relates to a lot of the things we'll talk about today, but that's a direction of change that we're seeing. And the simple answer to their question is yes.
Great. Kind of a tough question. Will an ALS patient who contracts COVID-19 be gasping for air, or would they pass peacefully?
Right. I saw these questions sent, obviously you'd sent earlier. It's a good question. I think it's a question that one can ask for ALS patients in general who are towards the end of their life. And really the answer, regardless of whether it's COVID or pneumonia or respiratory failure is that we can control discomfort at the end of life. That's something that we can do very well, and we strive very hard to do. And the way we do it is through palliative care, through hospice care. Now, I think one has to be aware that on top of any disease, if you suddenly have a worsening outside of where you thought you were going to be, how do we react to that? The answer is, contact your doctor as soon as possible. Your pulmonologist, your neurologist, our clinic, whoever your clinic, who your doctor is. We can even get hospice to the home, even if we hadn't anticipated that, in a very short time frame. And so, and for those who haven't talked to their doctor about what hospice is, just to give a short view of that, a lot of times people think that's just the end, and that's not about living, that's about dying, right? But really, it's not the case. Hospice is just as much about really focusing on the comfort of the patient, not prolonging their life for the end of just prolonging, but making sure that every moment of their life is as comfortable as possible. And that is exactly the approach. And in this scenario, if it were to happen to an individual related to COVID, that's exactly what we would do. And my expectation is that there would not be discomfort with breathing, because we have medications that work very well for that at the end of life.
Got it. Thank you. Sort of related. Why not test all ALS patients now? It would help our families and caregivers and give them hope. Yeah.
Well, that question is asked by just about every group these days. One of the issues that we're clearly facing, and I think everyone recognizes, is that we don't have the capacity to test everybody whenever we want to, even healthcare workers, right? Which is another population, mostly because we don't want to spread it to our patients, and we want to know. So the answer to that is changing yet again. If you may be aware that really the way in the United States we've rolled out testing has been on an individual hospital basis. There is not a nationalized system for testing across the entire country or even across the entire state, or rarely across counties. It's actually been individual health systems that are having to reestablish the testing. And our health system is doing that now, and we're just expanding our capability. And so the answer is, we're going after healthcare workers as much as possible, as well as then vulnerable populations. And then we'll try to expand as much as possible. I mean, really, the answer is it'd be great if we could test everybody every day, all the time. I mean, I know that sounds silly, but we need to know, because there's this asymptomatic carrier phase where people are contagious. That's really the issue, right? We don't want to spread it to people who are vulnerable unexpectedly. And that's why testing has been effective, and it's going to continue to expand. But the answer for right now is we simply don't have the capacity to test all ALS patients or all patients who are vulnerable.
Okay. And related to that, someone asked, she says, we wear a mask to prevent inhaling COVID-19 droplets that we might be exposed to, but aren't our eyes vulnerable as well? Can airborne droplets land on the eyes and infect us?
Absolutely, they can. And if you see healthcare workers on the television working with COVID-19 patients, you'll see that they're wearing full masks in terms of eyewear protection. The best systems are essentially almost like a scuba system, which completely covers the face, the mouth, and the eyes. So, this question of why in public you would not want to do that, a lot of what was, and remember, we're learning something every day. I know you hear this all the time, but what's generally been said is, if somebody coughs, you're going to see a spread of the virus 8 feet or something in that range, meaning through the actual droplets. So unless you're within that range of a person outside, you're probably not going to inhale it or get it in your eyes. But if you were, and to this person's point, and you did not have eye protection, absolutely, you would be exposed and you would be at risk of infection. So, the more recent suggestion that we all wear masks all the time is just because we're still trying to understand whether or not there are certain scenarios outside of the hospital where it could be aerosolized or airborne further. in which case normal breathing might generate infectious particles, and it would be more protective. And I think the concept is that those would be less able to be exposed to, say, the eyes, but more if they were inhaled, which would be more protective.
Gotcha.
But again, as you guys all know, it's a moving. We hear different things every day from the CDC and our own scientists. So we're just trying to come up with a policy that fits the best science we have at the time.
Makes sense. Okay. Next question is, my husband is my main caregiver. He needs exercise to remain healthy, and swimming is his exercise of choice. Is it safe for him to swim in a public pool during this crisis?
Right. Well, I think the answer is just public pools aren't open, and therefore it's not really an option. You know, this issue of whether water is capable of spreading the virus more than airborne is still not known. In part, some of the folks may recall that there was a scientist down in San Diego who kind of started this discussion about how certain situations could lead to spread further than 6 feet and require different scenarios. And one of them was water, and that led in part, or impacted the decision to close the beaches and the water. At this point, I think it's continued to be evaluated, but public pool settings are staying closed. And I think just the congregation of people, you'd have to control the flow very carefully. Even if the pools were reopened, you wouldn't want to have as many people as typically are in such a small space in that setting. So I think that's going to be a while before we are able to reopen those. And so I guess the answer then is he has to try to find some additional options for exercise, as we all do.
Right.
Which is tough, easier said than done when you have a favored exercise method. But
exactly. Yeah. Okay. And this question is coming from someone who uses a ventilator. Does being on a ventilator reduce the likelihood of contracting COVID-19? And the second part is, if afflicted with COVID-19, will vent pressures begin to increase?
A good and complicated question. I think to the first part, it's not expected that the susceptibility would be increased or decreased. It would probably be about the same to an individual who is on a ventilator. I think the real question is the second part of the question is if one were to contract COVID-19, and really then it's not just having COVID-19. One can have fever and myalgias and flu-like symptoms, as we all know, without necessarily having significant respiratory compromise. But if one were to get pneumonia, it would definitely require changing the settings on a vent. And so, our pulmonologist, who I work with a lot, Dr. Ashraf LCA, who's in our clinic every week, we kind of have been discussing this on a frequent basis and on a patient-by-patient basis who contact us. So I guess the answer is, if you develop symptoms and you're concerned, or you think you may need to have your vent settings looked at or considered, let us know. And we have been making some remote changes for people. No one who has sort of full-blown COVID-19, but who had some respiratory symptoms, and we thought we wanted to adjust. So we can make those changes remotely.
Okay, good to know. How does COVID-19 impact the use of breathing assisting machines like a BiPAP?
So it doesn't affect it at all from the perspective of, if you need BiPAP and you're using it at night, for example, which a lot of patients do for sleeping, you should continue to wear it. And really, if you develop symptoms of difficulty breathing or changing, you think in the need for BiPAP, again, the first answer is contact your doctor, your pulmonologist, discuss those symptoms. There is an issue right now with patients going to the emergency room or health facilities who have COVID-19. And it's an important one to discuss. It is not a uniform across facilities, but it has been the case for us. That is that BiPAP actually will increase the amount of aerosolization and spread of the virus. So when a person comes to our hospital, typically, until we know they do not have COVID-19, we don't use BiPAP in them. This has not come to be a problem for us, but it is a theoretical problem we've discussed several times, which is if we have a patient who has ALS and they develop problems with breathing and need to come into the hospital, but we don't know whether they have COVID-19 or not. That's where it will be an issue. So we have the capacity to put them into what's called a negative pressure room, but there are only so many of those in any hospital, and some hospitals don't even have them. So if they don't have one, they may actually feel pressured to either to not use BiPAP or to pursue invasive ventilation, meaning to put an endotracheal tube in to address the patient's shortness of breath. Again, this has been so far for us more of a theoretical problem, but it's one that it even further says, hey, contact your doctor, contact your pulmonologist if you think you're having more problems, so that we are ahead of this, so we know if you are going to be going to emergency room, we'll call them. Certainly for ours, that's what we would do. We'd say, this is what's happening, this is the plan. We could have people go directly to the floor if needed. We would know where that would be, not come into the emergency room or go into a negative pressure room. Those would be the kinds of things that would have to be discussed until we knew whether they had COVID or not.
Great, this is such good information, thank you. A question from someone whose sister has ALS. My sister is about a year into her ALS and has progressive weakness in her extremities that contributed to several falls over the last year. At her level of the disease, how dangerous would the COVID-19 virus be if she gets full-blown symptoms?
You know, I think the implication there is that she didn't mention anything about her respiratory status, but that her sister's primary issues are with her limbs and with walking, in which case, if she has normal breathing function, then the consequences of getting COVID-19 are actually pretty much the same as anyone else's. The biggest concern we have with ALS patients who get COVID-19 is that they will sort of have a double hit on their respiratory system, right? That they'll develop a pneumonia on top of the difficulty with expanding the lungs and coughing and secretion control. So if those are not a major component, then it's actually, it would be likely it would be the same as anyone else. And you know, this ties into the immune system and what goes on with COVID patients, and probably a lot of the people on the call and the webcast know that there seems to be a really severe illness that patients get, the one that leads them to get into an ICU, that really relates to the immune response to the virus as much as the virus infection itself, right? So many people are getting the virus or getting mild symptoms. They may even get moderate symptoms, much like a flu, but they're not going into the ICU on a routine basis. It's if they have a much stronger immune system reaction that seems to be what tips them over and really need that intensive care and make it hard to care for them in the intensive care, something what's called a cytokine storm. But that's really just a very strong immune reaction to the virus. And it can happen with other viruses, not just COVID-19. So if that occurs, that becomes hard to care for anybody. It would be doubly hard to care for someone who had ALS, but that aspect, even as people already know, when they hear about young, healthy individuals or young individuals in general who are getting severe COVID, it's that they're having problems with. It's that really strong immune reaction. So then the short version of or the tie-in to that is that ALS patients, we don't think have a problem with their immune system itself, right? We always tell them, go ahead and get your vaccinations, everything else, because your immune system is going to respond properly and protect you from infections. And so they're not immune compromised. And they don't have that concern as we do for some other patients who have cancer, other things, or on drugs that might compromise their immune system. That does not seem to be as much of a problem for ALS.
Okay. And has ALS been determined to be what they've called an actual increased risk factor for people diagnosed with COVID-19?
I think the answer to that is no. It's not been determined to be. In other words, there's not published data or reports coming out from physicians in Italy or other places that the ALS patients are doing worse than other patients in a way that we can specifically understand. The expectation is very much so that we need to protect them, that they are at higher risk because we know of their respiratory compromise. But the short version of that is until we sort of gather more data as a world, really, and some of these other countries that have been facing it. And I do know that the Italian groups are really looking to report how they're dealing with it and what their complications are, but that information is not really out there yet. So, and we will react to that as we see it. Regardless, we're treating them as a high-risk group simply because we know that with the additional compromise of respiratory function secretions, it would be a problem, a bigger problem than it would be for someone else.
And what about the pneumonia vaccine? Does the pneumonia vaccine prevent or help prevent COVID-19? And second part of that is, can COVID cause lasting lung damage?
So the answer to the first part is no. It's a different type of virus, and each type of virus and potentially different strains of virus need different vaccinations. And so the pneumovax or the flu vaccine do not protect against coronaviruses. And of course, everyone is looking towards developing a vaccine, and that's really going to be the key for all of us to changing the spread of this virus through the population, regardless of who we're talking about. So that's the first part of the question. The second part was lasting lung damage. It really depends on what the problem was, but just like any severe pneumonia, again, if you have a functioning immune system and you don't have other compromise of your lungs, so people who may have pre-existing lung disease, but the answer is no. If the infection can be cleared, then you wouldn't necessarily have long-lasting lung disease. But let's face it, it's early days. And we can't always make those generalizations be true. We don't know for sure.
Makes sense. Switching topics just a bit, how are the restrictions of COVID-19 impacting multidisciplinary care and the ALS centers?
Thanks for that question. That is such a great one because we're all very occupied with trying to understand that. The first impact has been many of us, and ALS Association Golden West and Fred Fisher and others really decided early on we should get all the clinic directors together and talk about this issue. And really we decided based upon what we were seeing and sort of different institutions that we would really push towards going completely virtual and trying our hardest to go to completely virtual models so that was an option. We still have individuals coming into the clinic if there's this particular reason why they need to, but we're trying to avoid it for now, and because we wanted to essentially block it entirely and see if we could do everything virtually and then start to reopen in a graded fashion as we knew it was safe. So that's the answer. We've and our clinic and several others, and as I said, Kathy and UCSF, who you're going to hear from in a few weeks, really literally overnight did an amazing job of switching to that model. And we're all learning it can be done. Now, we're also learning that it has its strengths and weaknesses. A big strength being you don't have to drive all the way to Cedars-Sinai or to UCSF or to wherever it is that you're going. The drawbacks are we know that there's more that one can get from a face-to-face interaction with the physicians, with the other providers. And so what we're trying to figure out is how do we understand what the things we can do well in that setting, the things that we don't do well, and address them. And the other example being monitoring people's breathing. There was a question that was sent in. How do we monitor people in terms of their progression from a telemedicine, telehealth perspective? And in fact, we can do some things quite well because many of the patients may know we do the ALS functional rating scale is really a questionnaire. And so we can give that over the phone just as effectively as we can in person. The things we can't do as well, look at people's breathing function. Really requires that we have them breathing into an apparatus at this point. We're all looking towards better ways of doing things. And I think, again, one of the silver linings of these kinds of events is we are forced to look at these things early before necessarily we thought we would. And that would be, can we measure this in different ways? Can we use app-based tools to listen to people's speech or quantify abnormalities or even their breathing? Can we imagine a world where we can send a device to someone's house and it just hooks up to their iPhone? And the answer is, of course, yes. And this, it's not there yet, but this may be one of the things that pushes us towards doing that. So we're pushing the technology to allow us to evaluate patients more remotely. I don't think, interestingly, there's differences of opinions on this amongst the different clinic directors. So you'll get to hear some different answers. I mean, I personally don't think we should just get rid of all multidisciplinary clinic model, clinics themselves. The analogies were made by John Katz, one of the clinic directors. Hey, this is Amazon. We all used to go to the mall. Now it's Amazon. You can just get whatever you want, whenever you want. You can see your doctor, you can see the PT. And that's true. There's really going to be some positive change there. There may be situations where that's the best care provided to the patient because of convenience. But then I think there are going to be other scenarios where, and I joked back with him, well, Amazon shut everything down and they reopened their bookstore so people could go back and look at things in person.
Yeah.
And so, you need both. And what we're going to learn from this much more quickly, instead of this sort of glacial shift towards telehealth that we were seeing before, is that there may be a very rapid shift in the people who that works best for. We provide care that way, and then for others, they come into the clinic, and a mixture of both. And I imagine that's really what it will be, that we can do both of those things and provide better, more convenient care. So it's a great question.
Yeah, great. Well, great answer. So thank you. Question about clinical trials. I'm concerned that all the attention on COVID-19 will slow down progress into ALS treatment and prevent me from getting connected with a promising treatment. Does the current COVID-19 crisis affect ALS research, clinical trials, and treatment groups?
Another great question, insightful question, because I think the person who asked that probably sensed that the answer is yes. I mean, and that indeed, the first response of most of the clinical trials going on was to say, let's either put a hold on new enrollment, or if it was an observational type study, to switch to a telemedicine type visit so that we didn't have to have the patient come in. And because that required a shift, there was clearly a slowing. Even clinical trials that were sort of in the startup phase, meaning they hadn't really fully started. What one of the things it requires is that there's something called a site initiation visit, where the sponsor comes to the site and they all confirm, hey, we have everything we said we'd have, everything's in place. And that's not allowed right now. In fact, essentially all of those have been shut down. So there have been effects on clinical research, but it has not shut down entirely. And so, for example, at our institution, and again, from our discussions with the other clinic directors, I think it's roughly the same for people who are already in interventional trials. For our examples would be in Brainstorm trial, who are getting procedures, and it has to be on a certain schedule. We've been continuing to do that. Patients have been continuing to come into the hospital. For the gene therapy trials where there are infusions, that's the same. If there's anything where there's a medication that can be changed remotely, we would certainly do that instead. To minimize risk, but we have not shut it down entirely. And so, because our view, as much as I think that patient or person's question was, is this is essential. This is not a scenario where we can simply shut everything down and wait a year. Not only for the trials that are ongoing, and the patients who are in those trials, if we were to shut down those trials, we would actually lose the data that we've had from that group of patients who are sort of in the middle of their treatments. That would be devastating to those patients. It would also be devastating to the trial itself and the patients who were in it before, because those trials are powered with a certain number of patients to get the statistical answer. Does this work or not? And so we've all taken a pretty strong stand, both the sponsors and the doctors who are doing the interventional trials, that we need to continue them as much as possible. So what I think is going to be the next phase of that is just like we talk about reopening, restaurants and bars or whatever, and we're actively discussing in our institution on an every 2-week basis, what things can we reopen, what things can we safely move forward and change what our current policy is. And I think that then once we allow travel again, you're going to see site initiation visits opening up, monitoring visits, the types of things that need to occur for these studies to continue. And I think that's going to start happening, relatively soon, because those things are very essential functions in healthcare.
Thank you so much.
Yeah.
Yeah. And just related to the trials piece for a bit, a question about Neurone. When will this be available for the Right to Try program? We've offered to pick up the cost for this procedure, and we were still told no. What's the purchase of the Right to Try process if we are unable to use it?
Yeah,
or the purpose of the
good
right to
question,
try.
and yeah, of course, and it's our first one not related to COVID, but it's nice to cover, really. So, the right to try is a legislation that, prior to being at a federal level, essentially every state who put it up had supported it, and it had been around for years. And the idea is that a medicine that's gone through early phase clinical testing to prove safety could be made available to patients who were in need and didn't have an option to go into a clinical trial. And really, as one saw, as that law moved like wildfire throughout the states and then to the federal level, there's just widespread support. The problem is, in fact, that there's no, and I'm not saying necessarily it's a problem, but from the perspective of the patients, the companies are not forced to provide anything. And that's, I think, the difference. The companies are allowed to, they're not forced to. And so if you give them a certain pile of money, they don't have to give you that treatment. That's not the way the right to try law is written. It does allow them to do that under certain circumstances if the drug has been proven safe to be, et cetera, but it leaves it up to the companies. And the companies then have to decide, either based on the type of therapy that they have, whether it be drug or a stem cell or other thing, is that feasible? The answer, I think, in part for the neurone is that the feasibility problem, it's extremely hard to make those cells, to deliver them, to monitor safety. I think, again, I don't want to speak for Brainstorm. I think you would literally have to ask them, as the patient is implying, and maybe they did. I'm just trying to give a broader view of it all. That's a big part of it. And then the other is for drug companies more in general is, how does it impact their drug development program? And they're trying to incorporate all those decisions, as well as having things like expanded access programs, open label extension phases to these trials, and right to try is sort of a piece of that. How do we get access for patients who don't have it? So, expanded access is another way, and I think I'm seeing more of that. I think if the patients want to push, it's another thing that to sort of discuss with legislators and others, create funding availability for those to occur, expanded access programs, and make it easier for the companies to do it rather than just say, hey, there's a law saying I can do it. It's not been very effective, at least in the ALS world. I don't know clinical trials outside of, but I would say that the right to try law has not led to a lot of people being able to use it. And that was the last part of the question, what is it good for? And I think, we have to make it more reasonable for the companies to get those drugs available to the right patients in the right setting. That's the complicated answer to what was an insightful question, which is it's not working perfectly.
Great, that's helpful though. Thank you so much. I'm gonna go all over the place here for a minute because we have all different kinds of questions. Does biomagnetics help fortify immune systems to face COVID-19 better for people with ALS? Well,
I smile because this is one of those scenarios where I yet again learn something from my patients, and so. And there's been many scenarios of this in the clinic. I don't know enough about biomagnetics and its influence on the immune system to answer that question. So I guess I simply have to defer. Maybe Kathy will know the answer to that one. I apologize.
Okay, we'll save that one. That's okay.
But so just so the person knows that my general strategy for this is I look it up, and next time I know the answer, and that will be mine again. The first time I heard about ozone therapy, that was my answer as well. I don't know what that is, and after that, I've been able to advise people on it, but I actually don't know.
Okay, fair enough. We love the honesty. Next question is, I've heard that with conditions like Parkinson's, stress can increase, just like stress of facing a pandemic can increase symptomatology, leading to what may be perceived as progression, but it's actually just temporary. Is this also true with ALS? How does stress impact symptomatology and progression?
Well, for symptomatology, that question is exactly right in terms of the aspect. In other words, it does lead to a worsening, and we know it quite well for really every neurodegenerative disease. whether it's Alzheimer's, Parkinson's disease, ALS. Patients who are under undue stress are going to have worse symptoms, are going to have more fatigue, are going to have more weakness. And we see this all the time, not just COVID related, but I'll bet you that many patients are noticing that or experiencing that, from the stress that it's placing on all these families, all of us, the decreased sleep and the too much TV or whatever it is, just about everything. I think that's right. Now, whether it affects, the second part was progression, and that we don't know, but we don't think so. It seems as long as the stress is transient, right, that it would not affect the long-term progression of the disease. But stress, the other part is it's very hard to measure. So we haven't been able to do clinical studies where we look at the amounts of stress that different people have and how it affects their progression rate. We only really have anecdotal experiences of different physicians. And so I think what that means is that, yes, the first part is likely true. The second part, I don't think so. I don't think we have evidence that a transient stress that makes those symptoms get worse, that can't go back to the normal progression rate.
Okay, thanks. And I think you touched on this question a bit earlier. This person may just not have logged in at that point. Are there new restrictions on respiratory tests such as SVC and FVC, since those tests may aerosolize one's saliva?
Yes. We talked about BiPAP, but we didn't talk about FVC and SVC. So forced vital capacity, supine vital capacity, slow vital capacity. But each of these are breathing tests which most of our patients have every time they go to the clinic. Before we stopped doing the multidisciplinary clinic visits, we actually stopped doing that. It was only 1 week, but where we still were seeing patients, and we said that doesn't seem like the right move. And then after that, we went completely virtual, and now we'll be reopening. But I would say that until we have, a better control on the spread of the virus, we probably are going to minimize those types of testing as much as possible.
Okay.
And that is a problem, by the way. Just to flesh out, I think, it was another point of discussion amongst the clinic directors. How are we going to monitor respiratory status, respiratory progression? But the other part of that is a lot of what we use is not just the number. It's really, how the patient's symptoms are. Are they able to lie flat at night and breathe comfortably? We can order sleep studies in the home, and that's another way that we can look at it. So we've already started to try to think of alternatives, and we can do pretty well. I actually would say that because the symptoms of the patient often drive us a lot in terms of how we decide whether to do non-invasive ventilation and when, and how to adapt it and adjust the levels.
Okay, terrific. You mentioned at-home monitoring of a patient's progression and using the ALS FRS administered over the phone. How often do you recommend patients check in on their progression? Do you recommend patients use the patient-reported version of the ALS FRS to check on their own progression as well? And can this data be used to conduct research?
It's great questions, and so the answer in part is that the scale itself, regardless of how it's measured, is somewhat noisy. And that is as patients who, if this person has done it themselves, they'll know that sometimes, on a day-to-day basis, it will actually change up and down because it's based on functions. And some of those things might be subtle in terms of the differences between a different point on the scale. The patient-reported scale certainly is better for patient reporting. You can use the regular scale if you have a person who you're talking to and reporting it. But it also comes down to, how do we measure progression without having to have a phone call, without having to have someone come to the house or the person come to the clinic? And are there ways? So there are patient-reported questionnaires, and then the others are, are there apps? Are there actimetry, all these other things which are really under active investigation? I think we all know the answer is likely yes. Likely we are going to be able to measure progression in a lot of spheres of function using sort of non-invasive monitors and other things. But we're still validating all of that, and we haven't rolled it out on a widespread basis. I guess the other thing I would say is that I wouldn't preoccupy oneself too much with doing it too often. we usually do it as every 3 months. And I think even then we see noise, right? We see it going up and down. It's more the trend. So I think doing it a lot more frequently of that may cause more anxiety than necessary. And you're really just reading noise or stress levels that day or lack of sleep the previous day, things that can influence on a short term.
Okay, no, that's great advice. For respiratory, physical therapy, occupational therapy testing measures that you do with patients during clinic, it can be challenging via telemedicine. Are you modifying what you're doing to obtain those measures to get the best information that you have available?
We are, there's a lot of developing literature on telemedicine in general, the neurologic exam. But it's limited. There are certain things we can do relatively well. I sort of learned that this one here is really good, right? This is our ataxia testing, and how coordinated someone is. You can actually see it almost better on the screen than you can in person. But the other ones that, in terms of quantitative strength measurements, observing fasciculations, doing reflexes, sensory exam, all of those things are challenging. There are some guidelines, and we use those. You can engage the caregiver, of course, to try to do some aspects of the exam, and we observe that. So the answer is we can do pretty well, but we can't do it as well as if we do it in person. So therefore, in terms of the assessments, we're basing it on function. If you're talking to the occupational therapist about how things are going with buttons or keys or writing or communication, they're going to respond much more to that. They're going to watch you do those things and try to understand, hey, I can see that this person's having trouble, with this type of a movement. How can I address that? And do as much as they can visually, as opposed to being based on the neurologic exam. But that's one of the things we're learning, as we talked about, what can we do better and what can we do worse? There are a few things that we do better, and there are some things that just aren't as good. And it's ripe for technology development, right? Maybe we can send something off to your house and, you lift it up and it tells us some quantitative measure. We all know that there's got to be some tech savvy people out there in Silicon Valley who can come up with this stuff, and maybe we can make it happen faster with some of this push that we're seeing now.
For sure, that would be amazing. Does having high blood pressure or a previous heart attack place you at increased level of vulnerability?
For COVID-19, I guess is the.
I guess it doesn't say, but I think
okay.
so.
So I think high blood pressure, I don't believe so, no, but I think, and the second one was, heart disease. I mean, really any bad pre-existing medical condition, because in theory, if you then have an additional compromise, so this whole idea of what is a pre-existing medical condition, that it's really just the idea that almost anything that's a severe condition of bad, heart function, lung function, otherwise, if you were to then get a severe infection, you have a compromise of the circulatory system of your breathing, that the two things would act together and would be bad for you. This is not to say that everybody who gets gets COVID-19 who also has any heart disease at all has a bad outcome. It's just that's our worry. That's how we're trying to advise patients on how much risk to take, is by taking those things into consideration.
Sure. Another question, I hear that a BiPAP can be changed to be a ventilator. Is this something to get ahead of before needed with COVID-19?
Right. So the answer is yes. There are certain types of BiPAP machines. The machine itself can be used either for BiPAP or as a ventilator. And the type that we really use for all of our patients is one of those. In fact, most of the clinics would use systems like that. They're very, we're able to adjust them very well in terms of the amount of pressure on inspiration and expiration and triggering and all that. So the answer is yes. In terms of getting ahead of, I think the bottom line is you have that machine, then you're ahead of the game. The idea is you don't have to change it. You would have changed a bunch of settings if you went from non-invasive to invasive ventilation, but that's already the case. Now, I would not say that we ever argue or would in this case that doing sort of early invasive ventilation when it's not necessary is a good move. That it's not, because as if the folks on the webinar haven't already talked about that transition with their doctors, it comes with a lot of other things. Moving to invasive ventilation in terms of the inability to cure, difficulty with communicating, not being able to use voice, not being able to swallow, having to use everything through a G tube if they aren't already, mobility changes, a lot of things that really need to be discussed in that whole sphere. And so, no, I don't think that if a person's on BiPAP, I guess the move of just having the right machine is already the right move. And and again, as our pulmonologist has been telling me, and I've been saying the same, call us. If you've got a question, let us know. The answer is probably different for almost everybody, because everybody, ALS is different, as we already know.
Sure. This is probably a tough question to answer, but I'll throw it out there. My sister-in-law with ALS wants to know, at the stage of having respiratory problems, should I decide to be on a ventilator?
Well, that ties into our last question, doesn't it? Which is the discussion of whether or not to go on a ventilator, meaning having invasive ventilation. I guess I can certainly give a short version of my discussion with patients for this. And the answer is, yet again, is it's different for everybody. And one can imagine scenarios where their person's breathing is really compromised. There is something called respiratory onset ALS. Where the diaphragm is early and most involved, and most other muscles are relatively preserved. Patients who are in that setting are making a decision about that based on information that they may have a very solid quality of life in a lot of spheres that bring them joy, and that they want to have that prolonged for a long period of time, in which case having a ventilator is not a bad decision for them, and they say that makes sense to me, because I would get to be able to do all of these things. I could, in some cases, believe it or not, people can be strong enough that they could carry their ventilator. This is the extreme example, right? But that would be a different type of a patient than a person who's completely disabled, unable to care for themselves, or already has severe difficulty communicating. Their decision of whether or not to go on a ventilator is different. And so, again, each of those discussions is different. I really encourage you all to have them with your doctor. And in fact, this will give me my chance. Our clinic coordinator, Tammy Kendra, said, hey, remember, because I told her, hey, let's reach out to all the ALS patients right now and say, I know everyone's trying to stay at home, but why don't you contact your doctor and talk to them about a pulse and advanced care directive. It's a great time. We should be doing it anyway, but I think it's a great time to say, hey, this would be a good phone call or a video visit. Let's get those things squared away. And it also allows them to talk to you about your personal situation with your respiratory function, your risk of COVID, and how you would react to that. So I think it's a good time to bring that up too.
Wonderful, thanks. And I know we are coming to the end of our time. It's about 5 till 6. I have a completely off-topic question that's just for fun from someone. He says, what's the make and year of the guitar on your wall? Before my progression, I was a musician and an instrument builder, hence my interest.
Yeah, so thank you. That is a Gibson L10, so it's a hollow body guitar. I bought it at a swap meet in St. Louis when I was a neuromuscular fellow. So 1932, I believe. It's pretty old. It's really cool.
Wow.
I don't play it that much. There's another one over there you might be able to see in the back corner. That one is much more playable. The sound on this one for the musician who may have played these hollow bodies is really interesting. Oh, God, someone has to strum it. No, I'll draw the line. But no, it's really cool, and you often see those turned into electric guitars or precursors of electric guitars. They're pretty cool. So, thanks for the question.
Very cool. Yeah. Well, it completed your cool background. So thank you so much.
Thank you.
Well, thank you, Dr. Baloh, and thanks to everybody for all of your important questions. This was such a wonderful opportunity to hear and learn more. Thanks again, Dr. Baloh, for taking the time and this wonderful presentation. We're so grateful for your time and commitment to our chapter and to the ALS community. I want to thank all of you for joining us tonight, and a big special thanks to our generous sponsor, Mitsubishi Tanabe Pharma America. We will be hosting more sessions like this in the near future, including Monday, May 4th with Dr. Kathy Lohman-Hurst from the ALS Center at UCSF that Dr. Baloh mentioned on the call tonight, and Monday, May 18th with Dr. Steve Finkbeiner with the Gladstone Institute at UCSF. And if you too would like to support this free educational programming, please consider making a donation today at give.alphagoldenwest.org. Lastly, please watch for the short survey on tonight's presentation that you'll receive via email in order to help us plan for future educational programming. Thank you so much. Be safe and well, and have a great night.